Muy buenos días a todos, muchas gracias por estar ahí. Continuamos con el segundo día de nuestro Congreso y el primer simposio de la mañana refiere a metabolismo y terapia nutricional en el paciente crítico sobre los más recientes avances. Este será un simposio donde tendremos a 5 speakers de primerísimo nivel. Comenzaremos con el doctor Pierre Singer desde Israel, que nos va a hablar sobre el metabolismo y los requerimientos de proteínas en los pacientes críticos. Por cierto, es un tópico sumamente actual y es un tópico también ciertamente controversial. El doctor Pierre Singer es ampliamente conocido por todos ustedes. Francés de origen, es actualmente y desde hace ya varios años director de la unidad de cuidados intensivos del Rabin Medical Center en Tel Aviv, en Israel, profesor de anestesia y cuidados intensivos en Tel Aviv, con múltiples conferencias y artículos con peer review. Pierre Singer ha estado en varias oportunidades dictando conferencias en la región, por lo cual para nosotros es un honor contar hoy con la presencia del doctor Pierre Singer. Adelante.
Hello, everybody, and thank you for giving me the opportunity to speak with you in this Uruguayan meeting on protein metabolism requirements in the critically ill. These are my disclosures. And actually, the main messages of this talk will be to look to the protein going in and out of the body in the daily practice, to raise some studies that we performed recently about tracers in the acute and post-acute phase, and to try to understand what is the effect of early high protein administration. Well, to go back to the physiology, we know that some normal volunteers will take around 70 grams per day of protein and will oxidize them every day. But there is an exchange between the body reserves, mainly the muscles and intestine and the liver, and the free amino acids, making proteolysis or synthesis of around 300 grams a day. And this is a zero balance. Usually when a patient is in a normal condition, he will not lose too much protein and not build any protein, but this will be stable. If there is an acute disease, there will be a different, larger turnover of amino acids around the body. What is happening? There is, in the acute phase, early period, a huge proteolysis because the body needs to do substrate endogenous production. And this is leading to a very severe catabolism. This is usually taking 2 days. After these 2 days, we go into the late period of the acute phase, as described in our ESPEN guidelines. And in this acute phase, still there is a loss of protein and muscles, but it is decreasing progressively. And after altogether a week of the acute phase, we go in the post-acute phase, which can be continued by a prolonged stay and a continuous inflammatory and catabolic syndrome, or some rehabilitation and anabolism so the patient will be able to do better. Immobilization is very bad for the critically ill, because even if you give to the patients a large amount of amino acid infusion, when the patient is immobilized, there will be a huge muscle loss and a decrease in ability to synthesize new protein. This has been also very nicely described by Putucherry in a JAMA paper already almost 10 years ago, showing by biopsies that the patient was losing muscle in a large amount. 10%, 20% of the muscles are lost in the first 10 days. So that is a huge loss of muscle during the acute hospitalization. This can be measured by the CT scan. Almost all our patients are undergoing CT scan, and you have some very nice softwares calculating the mass of the muscle. And if you don't have a CT scan, you can use a urea to creatinine ratio that is giving you a biochemical signature, very, very predictive of the length of stay of the patients. In the patients that are staying longer, the urea to creatinine ratio will be higher. And this is true for the short stayer and the long stayers. Well, the patient is receiving protein intake, and in the body, there is some synthesis of protein, but it's slow, and a huge catabolism, making the balance negative. However, most of the people in the world are delivering protein in a lower amount, around 0.2 grams per kilo per day, as shown in the data provided by Nutrition Day by Michael Hismayer in Vienna. Patients are losing protein and muscle and amino acids and nitrogen in the urine. And more they are staying in critical illness, the bigger the loss of muscle. Nitrogen balance is obtained between the difference of what is lost in the urine and what is administered in protein in the body. And usually this nitrogen balance is quite negative, even so you give 1.2 grams per kilo per day in these patients. The consequences are complicated because patients who are so much catabolic, 1 year after, for instance, ARDS, there will be a decrease of 60% of the normal speed in walking. Only half of them can go back to work. The physical functions, the general health are really significantly decreased, according to Margaret Hertrich that published that in New England many years ago. We look a little bit deeper in the amino acid flu, which is occurring in acute illness, and together with two teams, one in Lausanne by Mette Berger, and one in Dallas and Houston with Mick Deutz laboratory to look to the tracers and an isotope study, we recruited patients that were at different stages of their illness. The patients from Lausanne were in acute phase, but the late period, and our patients were already in the post-acute phase. And what we did is to infuse a tracer mixture to our patients and to take samples very oftenly to be able to have an analysis. We knew exactly the concentration of the tracers that we were injecting. And what is interesting is that they did a very large sample of amino acids, not only phenylalanine like usually, but we had almost all the amino acids represented in this injection. And what you can see here in the leucine dynamics is that the whole body production of leucine was tremendously increased. And this is shown here in this graph. Phenylalanine is the same. And you can see also that there is a difference between the patients who are with a high SOFA, that is to say that the patients from Lausanne were more early in the disease. They have a higher energy expenditure. They have also significantly higher phase angle and fat free mass. Definitively, all the amino acids seem to react the same. And when you compare the SOFA score, which is high, which is earlier in the period, well, the plasma concentration is lower than in a later period. And the whole body production is elevated, but it's much more elevated in the later period when the SOFA became moderate. And this is true also even in citrulline. Even so, the levels in the plasma are low. And this is a summary of the whole protein, whole total body protein content and conversions according to all these amino acids we were studying, and most of them are much more higher in comparison to healthy volunteer subjects. How can we give more protein to these patients? Usually it's very difficult because we are limited. We don't want to give too much energy, and the products are not enough enriched in protein. So you can see in this study that the way to increase the amount of protein was to add a supplemental protein to the normal formula, so that the total protein intake was much more higher, here reaching 2 grams and more per kilo per day. Urinary nitrogen excretion was increased in this supplementation. But when you give more and more and more protein to your patient, well, your nitrogen balance is improving. It is less negative. And this is some of the objectives we have. And Dickerson shows that in patients with trauma brain injury, without brain injury. And Olaf Jonkers, Olaf Rojakers showed it also, putting many studies together and showing that the more you are administrating amino acids, the higher the whole body protein and net balance. That is to say that more protein can be helpful in the balance of protein in the body. But not every stage is the same, as I showed before. And Olaf Rojakers also looked at the patients after 30 days in the red. And these patients after 30 days have a significant increase in their ability to do protein synthesis. The protein breakdown is not significant in comparison to the early period. We showed many years ago that actually when you are administrating more protein, you are improving survival when you cross above 75 grams per kilo, 75 grams per day of protein. This is not the same when you provide more energy. When you cross 100% of the measured energy expenditure, you are increasing your mortality. That is to say that there is an association with overfeeding and mortality. There is an association with improved of survival and increase in protein administration. We are not the only one that found that. Peter Weiss in Amsterdam found the same, and he looked to a very long-term mortality, 720 days post-discharge mortality, significant improvement in survival, even so long after ICU discharge. He looked specifically to patients with frailty, with low skeletal muscles area and density, and these patients show the same that we found in our group. The more you were giving protein, this is below the curve here, you have an improving survival. Improving survival when you cross 0.7 grams per kilo per day. So a better survival when your patient is with malnourishment. And when you give him too much energy, crossing 100% of the resting energy expenditure, again, an increase in the mortality. It's not true for all the categories of patients. High protein intake is associated with low mortality, 45 reduction in mortality in the patients that are non-septic. When the patient is septic, there is no difference in mortality. So you can assess the muscle quality and quantity, the muscle density, and these patients that are receiving more than 1.2 grams per kilo per day and are with a low muscle mass, they have a better survival, as you can see. Protein requirements using parenteral nutrition has been also studied. And actually, this is the amount of protein that these patients were receiving, 1.2 grams. And what this study showed was an improvement in hand grip strength 7 days after the beginning of the study, improvement in nitrogen balance, and improvement in the muscle area evaluated by ultrasound. There is also a retrospective postdoc study looking to a large study, interesting study from the ICU, and showing that if the patients without renal failure were receiving a high amount of protein, while their mortality was significantly lower. However, most of the meta-analyses show that actually there is no significance in giving more protein in these patients. The only advantage of giving more protein is to improve the muscle mass. We did a more and more activation of the muscle during hospitalization, as you can see here, making these patients cycling. We also administered early protein in the first 3 days, reaching 1 gram per kilo per day. And you can see here the differences in administration of protein early or more late. And we found an improvement in this retrospective study in the survival, significant improvement in the 60-day survival. Another very interesting paper just came out 1 week ago, giving high protein intake and early exercise in adult intensive care patients. And you can see that the patients were very comparable between the two groups in terms of resting energy expenditure. They received more protein in the high protein group, but not more calories. And what we found is actually that there was an improvement in survival in the intervention group, significant, as you can see here, better mortality, ICU, hospital, and 6 months mortality, and also a PCS, a physical component summary, which was improved at 3 months, at 6 months, and the ICU acquired weakness was also decreased. Finally, I would like to show you a feasibility for achieving a high protein, low calorie enteral nutrition. The product is composed of 100 grams of protein per 1,000 of product. And of course, we administer that at the level of 1.2 grams per kilo per day in group A, and at the level of 1.5 grams per kilo per day in the group 2. These are the two groups, 10 patients, 22 patients. They are almost very equivalent. Energy expenditure measured by indirect calorimetry was very similar, but nitrogen in was increased. Nitrogen excretion was not increased. And as a consequence, we had a better nitrogen balance in the group receiving 1.5 grams per kilo. And we also could find that this was when the patient was improving with high protein, we had an increase in the phase angle showing a good health of the cell. So in conclusions, ladies and gentlemen, in daily practice, low protein intake and high muscle catabolism are very frequent in the acute phase. Increased protein intake may improve the morbidity and the mortality. However, we need to have more and more prospective randomized study. It seems that if we associate exercise, we will have better outcome results, and new enteral formulas that are more enriched in protein, but not so much in calories and energy, may be the adequate formula in the acute phase. Thank you very much.